AA is old, tired, wrong, and seriously infective. Did you know that doctors have completely redefined what alcoholism really is? They now agree it's not a disease but a mental disorder, and this revelation could change how we approach treatment. In this video, I'll break down why this shift is so important and what it means for anyone affected. If you skip this, you might never see recovery in the same way again. Did you know that doctors have completely redefined what alcoholism really is? They now agree it's not a disease but a mental disorder, and this revelation could change how we approach treatment. In this video, I'll break down why this shift is so important and what it means for anyone affected. If you skip this, you might never see recovery in the same way again. The plasticity of the human brain contributes to both the development of and recovery from alcohol use disorder, or AUD. Within the brain, individual genetic and environmental factors interact at molecular, neuronal, and circuit levels to influence a person's vulnerability to AUD. Thus, each person's path to AUD is shaped by a unique set of variables, and as a result, different people will have different levels of severity and types of dysfunction that may require different treatment approaches. Alcohol produces chemical imbalances in specific neurocircuits and can be neurotoxic. Chronic heavy drinking can, for example, damage brain regions involved in memory, decision-making, impulse control, attention, sleep regulation, and other cognitive functions. Once AUD develops and progresses, these and other brain changes can make it very difficult to stop drinking without assistance. Here, we outline a framework for understanding alcohol-induced changes in the brain, which can help you appreciate the challenges faced by many patients with AUD when they try to cut back or quit drinking. We then describe evidence-based treatments you can recommend to patients to help the brain and the patient as a whole to recover. A note on drinking level terms in this core article. Binge drinking brings a person's blood alcohol concentration to 0.08% or more, which typically happens if a woman has 4 or more drinks, or a man has 5 or more drinks within about 2 hours. Heavy drinking includes binge drinking and has been defined for women as 4 or more drinks on any day or 8 or more per week, and for men as 5 or more drinks on any day or 15 or more per week. How does the brain change as AUD develops? The brain mediates our motivation to repeat behaviors that lead to pleasurable, rewarding states, or reduce uncomfortable, distressing physical or emotional states. In this context, drinking alcohol can be motivated by its ability to provide both relief from aversive states and reward. These dual powerful reinforcing effects help explain why some people drink and why some people use alcohol to excess. With repeated heavy drinking, however, tolerance develops and the ability of alcohol to produce pleasure and relieve discomfort decreases. During acute and protracted withdrawal, a profound negative emotional state evolves, termed hyperkataphia. Hyperkataphia is defined as a hypersensitive negative emotional state consisting of symptoms such as dysphoria, malaise, irritability, pain, and sleep disturbances. Heavy drinking may also produce deficits in executive function that contribute to symptoms such as impulsivity, compulsivity, impaired cognitive function, and impaired decision-making. These brain changes related to excessive alcohol use underlie many AUD symptoms. Below is a brief overview of the current knowledge of the brain structures and circuitry involved in the cycle of alcohol addiction, which aligns symptomatically with moderate to severe AUD. The current AUD diagnostic criteria are listed in the core articles on AUD and assessment. Alcohol produces pleasure. Alcohol produces pleasurable or rewarding effects by increasing activity in brain systems related to reward processing. In the basal ganglia, activation of opioid receptors in the nucleus accumbens may be responsible for some of the pleasure associated with alcohol intoxication. In addition, alcohol causes the ventral tegmental area to send dopamine signals to the nucleus accumbens. Dopamine is critical for learning to associate alcohol and its related cues, people, places, or things, with the rewarding effects of alcohol. This learning process can lead to incentive salience, a motivation for reward that is driven by both a person's current physiological state and previously learned associations between cues and the reward. Some people are initially drawn to alcohol more for its rewarding effects, while others seek it largely to alleviate physical or emotional discomfort, as detailed next. Habit formation makes it harder to stop drinking. When drinking behavior patterns are repeated, the brain shifts control over the sequence of actions involved in drinking from conscious control via the prefrontal cortex to habit formation using the basal ganglia. This transition from incentive salience toward habitual responding, mediated by changes in brain circuitry, can make it more likely that someone will continue their drinking pattern and harder for them to stop. Alcohol initially reduces, then promotes negative emotional states and pain. Alcohol may temporarily reduce negative emotional states in part by dampening activity in the extended amygdala. This brain structure mediates the fight or flight stress response and helps us learn to associate certain cues with danger or threat. Neurons interacting within the extended amygdala release stress-related neurotransmitters, such as corticotropin-releasing factor and dynorphin, which in turn influence other brain areas involved in stress responses, including the hypothalamus and brainstem structures. Although alcohol initially suppresses activity in the extended amygdala and reduces stress responses, excessive alcohol use can lead to tolerance and the need to drink more to find relief. After drinking stops during withdrawal, the amygdala circuits become hyperactive, leading to hyperkatifia, or heightened negative emotional states, such as irritability, anxiety, dysphoria, and emotional pain. This discomfort, often described as misery, can motivate some people to drink alcohol again and repeat the cycle of drinking and withdrawal. Research suggests that among people with negative emotional states, self-medication with alcohol to help cope with mood symptoms increases the risk for developing AUD. Like its effects on emotional pain, alcohol can temporarily reduce physical pain. Research suggests that reduction of pain only occurs at or above binge levels of drinking, reaching a blood alcohol concentration of 0.08% or above, typically after 4 or more drinks for women and 5 or more drinks for men within about 2 hours. As blood alcohol concentrations decrease, however, the sensation of pain returns even more intensely. This again leads to a cycle of misregulation, that is, using a solution that ultimately makes the problem worse. The discomfort or misery felt during withdrawal, including negative emotional states, is the leading precipitant of relapses in patients recovering from AUD. The brain becomes motivated to continue drinking. As noted earlier, negative emotional states, or hyperkatifeia, can persist into protracted withdrawal and are a major driver for relapse in AUD. Also, the powerful effects of alcohol on neurocircuits relating to reward and relief cause the brain to attach strong motivational value, or incentive salience, to the cues associated with alcohol, whether in the immediate environment or recalled from memory. These environmental stimuli, or thoughts of them, can prompt a return to alcohol seeking via connections made between the prefrontal cortex and the basal ganglia using the neurotransmitter glutamate. Especially when combined with negative emotional or physical states, the sight or thought of alcohol or related cues can trigger cravings or the urge to drink. Executive function becomes dysregulated. Alcohol disrupts function in the prefrontal cortical areas involved in executive function, impulse control, decision-making, and emotional regulation. These functional deficits make it harder to withstand urges and avoid repeating the behaviors related to the addiction cycle, particularly in the face of stress and physical and emotional discomfort. In severe cases, impairments in prefrontal cortical function can persist despite months to years of abstinence, making it particularly difficult to recover from or compensate for deficits in executive function. Figure 1. Conceptual framework for the neurobiological basis of addiction and the brain areas involved. Addiction can be described as a repeating 3-stage cycle, with each stage associated with different brain regions, neurocircuits, and neurotransmitters. Drawn from decades of research, this cycle models processes that people with addiction may experience repeatedly over the course of a day, weeks, or months. The binge intoxication stage, associated with circuits in the basal ganglia, the person drinks alcohol, which activates reward circuits and engages incentive salience circuits. Incentive salience circuits link the pleasurable, rewarding experience with cues, that is, the people, places, and things present when drinking, such that the cues themselves gain motivational significance. These and other neurocircuits help develop and strengthen habitual drinking, and may lay the groundwork for compulsive use of alcohol. Neurotransmitters associated with this stage include dopamine, GABA, glutamate, and opioid peptides. The withdrawal, negative affect stage, associated with circuits in the extended amygdala. When the person stops drinking, reward circuit activity decreases while stress circuits activate. Together, these changes fuel negative emotional states such as anxiety, dysphoria, and irritability. The person feels alcohol is needed for temporary relief from discomfort and emotional pain. This stage involves the loss of reward neurotransmitters. As in a hyperdopaminergic state, the activation of stress neurotransmitters, such as corticotropin releasing factor, dynorphin, norepinephrine, hypocretin, and vasopressin, and possibly pro-inflammatory immune agents, and the inhibition of anti-stress neurotransmitters, such as neuropeptide Y, nociceptin, endocannabinoids, and oxytocin. The preoccupation anticipation stage, associated with circuits in the prefrontal cortex. The person with an addiction has impairments in executive function processes that normally limit impulsive and compulsive responses. The person has strong urges or cravings to drink, especially in response to stress, related negative emotions, and cues that are part of the incentive salience circuits activated in the first stage of the cycle. Neurotransmitters associated with this stage include glutamate and ghrelin. While people who drink heavily often enter the addiction cycle via the binge/intoxication stage, they can also enter via the withdrawal, negative effect stage by attempting, for example, to self-medicate physical or emotional pain, or the preoccupation anticipation stage by attempting, for example, to self-medicate a high impulsivity condition. For more information, see this 7-minute video on the neurocircuitry of AUD. Takeaways. Alcohol is dually reinforcing because it can both activate the brain's reward processing system that mediates pleasure and reduce the activity of the brain systems that mediate negative emotional states such as stress, anxiety, and emotional pain. Repeated excessive use of alcohol can lead to the development of addiction, which is associated with reduced reward function and increased activation of brain stress systems. The process of becoming addicted is thus accompanied by a shift in drinking motivation from positive reinforcement to negative reinforcement, during which drinking is motivated by attempts to reduce the emotional discomfort of acute and protracted withdrawal. Addiction and its associated brain changes can be understood as a 3-stage cycle involving binge intoxication, withdrawal, negative affect, and preoccupation/anticipation. The adaptability or plasticity of the brain is central to the development of addiction, to the effectiveness of evidence-based treatments, and to the neurological and psychological improvements in recovery.